and welcome to the Healthcare Career in Focus. In today's session, we're going to be looking at different aspects of nursing. So we are going to be joined by Diane, John, Gill and Vicki. We'll start with Diane, who's going to talk about being a nurse educator. Welcome, Diane.
Thank you. Good afternoon. So my name is Diane. I am an adult nurse, but my current job is the head of clinical education within the local hospital where I work. Next slide, please. So just going to outline a bit of my career journey. So how have I got to where I am today? So I started my nursing career back in 1986 when I was 18. And that was after a conversation with a careers officer. So I had said that I wanted to work with elderly people, and I was advised that to do that, the best route for me would be nursing. So I applied to our local hospital where nurse training was held back in the 80s, and I undertook a 3-year course to become a registered nurse. During this time, so from that point to today, I've worked in a variety of different job roles. So to begin with, I was working very clinically within ward areas, particularly care of the elderly. That was my first passion. And I was supported to undertake a care of the elderly specialist course, which lasted 6 months. So that enabled me to really gain lots of experience and lots of knowledge around that speciality, and also helped me to progress. Moving on from that, I then had a job in an acute medical ward. So we were receiving patients directly from the GP into that area for assessment to see whether they needed what type of care they needed, what kind of treatment. So it was very different every single day, very fast moving, but the variety of patients that you met was really rewarding. During this time, I decided to undertake my diploma. So one great thing about nursing is that you are often supported with further education. And because my course back in the 80s didn't come with an official qualification as it would today, I had my registration, but I didn't have anything else. So I undertook a diploma in nursing, for which I was successful. After a period of time, I felt that I had really given all I could to working within wards and clinical areas, and I felt that I needed a change. And it was at that point that I branched out into education. And that first part was working with medical students, teaching them clinical skills. So still working with patients, still having an impact on patient care, but a very different type of work. And it was during this period that I managed to get funding to do my degree. So at this point now I had a degree in nursing, which is what a newly registered nurse would come out with today. So I was playing catch up quite a bit. After this role, I moved into a different educational job, but then my dream job came up, and this was as a matron. And I was lucky enough to be successful, and I moved into that matron role, which I did for a couple of years. So again, working back with staff, working within the clinical areas, making sure that patients were receiving a really high quality of care. So my impact was very different. I'm not necessarily providing the care, but I'm making sure that the care that they are receiving was of, the best quality that it could be. I've then now moved into head of education, so I now have an overview of education for all of our non-medical careers. So that is all of our nurses, midwives, physios, occupational therapists, but not doctors. So that's a different department. So it's quite a wide range, quite a scope that I oversee. And it's during this time that I managed to get funding to undertake my master's in healthcare education. So I've continued my academic journey along with my nursing career. Next slide, please. So a day in the life of a nurse educator. It can be very varied, particularly because we are overseeing lots of different staff at different stages of their careers. So we look at our sort of our nursing assistants, our rehab assistants, as they come into these jobs. We do their training, we provide support, particularly while they're undertaking their care certificate, which is a mandatory national requirement. So we support with all of that. We support all of our students that are undertaking their pre-registration courses. So they're all at university, but come to the organisation for their placements. And then we also support our registered staff that want to develop further. So those that want to continue, maybe gain additional skills in the specialism that they're working in, go on to get a master's, become an advanced critical practitioner, really helping support people go through that career pathway. We provide lots of career advice. So we regularly receive emails from different staff that are saying, look, I've got a real interest in this. What would I need to do? Where would I get that advice from? Where would I undertake that training? And actually, who's going to pay for it? Because that can be quite a big challenge. So part of my job is to also manage the finances around the funding that we receive to provide professional development for our staff. So that's quite a new job for me. Within the other roles that I've had, I haven't had to look at a budget really. We've always been sensible about money. We know that it's important, but now I'm accountable for that budget. And it's quite a large budget. So that, at times, was quite daunting, but you get used to it and you live within your means. So that's really good. One of the really exciting things about this role is the ability to really progress nurse education. So we look at new courses. What do we think our staff need and how can we meet that need? So an example of this would be our Band 5 development programme. So when a nurse is newly registered, they will go through a preceptorship program, which is where we provide additional support and education to help that transition from a student to a registrant, because that's really daunting. It's a bit like when you're learning to drive a car in that, you're having lessons, and then that first time when you're in that car on your own, it's actually quite frightening. You have that responsibility. So we provide lots of support in that first year. But then we find that actually nurses want to progress, they're settled, they feel confident, they feel competent in their role, and they're ready to take maybe another step or to stretch themselves a little bit more. So we have a Band 5 development program that we designed and that we run, and we run that twice a year for it's normally between 60 and 80 nurses will come on that per year, and that sets them up to maybe think about progressing to the next level. So within nursing, we have bands. So band 5 is the pay scale when you are newly registered. Band 6 would be a sister or a charge nurse, and a band 7 is that senior ward manager or department manager. So offering these courses to enable people to progress is really useful, and actually it's really rewarding as well. Within all of this, there's an element of teaching. So I don't do as much as I used to, but it is really lovely to get out into the classroom, particularly with our new nursing assistants. When they come, I deliver a session about professionalism and career development. So again, sharing that knowledge that I've gained over the 30 odd years that I've been nursing, but actually sharing that to that new generation. And that again is really rewarding. Whilst doing all of this, it's really important that I adhere, or we as an organisation adhere to national requirements. So we have regulators, we have the Nursing Midwifery Council for nurses and midwives, and we have other regulators for other professions, and they will have requirements that we have to stick to. So we need to make sure that we are providing best practice, but in the boundaries of those national rules and guidelines. And then I've just put on there emails. So I do receive a huge amount of emails that I have to answer. I'm very good at delegating. So I have a team that I work with, and part of my role is making sure that that team have the opportunity to develop new things as well, to feel, to keep them interested in their jobs. So actually that's really useful in that I can pass some of those things on and let other people develop new courses, new ways of working, new ways to support our learners. So the day is very, very varied. No week is the same. Next slide, please. This will come with some challenges. So the first one really is about linking with the government policies and regulations. We know that we have a new government and they have said that they are going to review the long-term workforce plan that they have that was brought out earlier this year. So that's going to come with some changes that we will have to look at. Education is always changing. We have technology. So how I did my nurse training is very different to how it is today. There's lots of different technology that we use within education, so that's really important that I keep up to date with that. But that again can sometimes be a bit of a challenge. There's a challenge around finances. So as I've already said, maintaining the budget, trying to look at ways of delivering really good education, but maybe at the cheapest way possible without it affecting the quality. Simple things like finding space for education can be challenging. We're a busy organisation. Finding a room for face-to-face delivery can sometimes be a bit of a challenge. And then I think the one that hits me the most is that sometimes when you are not working clinically, you are no longer perceived as a nurse. So one of the things that we do quite regularly is we go out into the clinical areas and we actually deliver some care so that we keep those skills up to date. Next slide, please. There are lots of rewards that I find within my job. I
Hi, Diane, you've muted yourself.
apologies.
So that's not a problem. If you just want to go back to the start of your reward slide, that would
This
be
one. Yep,
lovely.
lovely.
Yeah.
Thank you. There are lots of rewards within my job. One of them is working within a really, really good team. We are a team that all have the same outcomes, all have the same aims, and we're all striving towards that quality education for our staff. Watching people develop is really rewarding. So, seeing someone at the start of their career and where they progress to, knowing that you've been part of that is rewarding. And actually, by doing all of these things, helping people deliver really good care is still having an impact on patient care. So, again, you still get that buzz that you are making a difference. I really like problem solving. That's the sort of person that I am. And actually, within this job role, there are lots of opportunities to do that. Next slide, please. So if I was going to give any advice to my younger self, it would be that you are more capable than you think. I never thought that when I was sitting in a classroom during my nurse training that one day I would be that person at the front of the classroom. That would never ever cross my mind. But actually that is what I'm doing today. So I think, that's what I would be saying. You are capable of more than you think. Next slide, please. So making a difference. I've split this into two. So the first one really is as an adult nurse, because that's fundamentally what I am. And I think we need to always be aware of the impact that we are making. So when you are working within a clinical area, you may see many patients in one working day. But actually, to that patient, you are one nurse. You are that one nurse that's looking after them. You may not remember the patient, but they will remember you. And that is a privilege, and it's also a responsibility. And also the fact that you are part of a person's journey, whether that be to, a recovery, to them going home, or whether it's to a peaceful end. It is a privilege to be part of that journey. Next slide, please. And then just making a difference as an educator. You are helping people recognise their potential. And you are providing people with the skills and the knowledge that they require to enable them to do their job better. And ultimately, that is going to enhance patient care. And I think the one thing that we all need to remember is that we are all patients at one time or another. So what we are doing to help strangers. We are doing it to help our family. You're also doing it to help yourself. Next slide, please. So finally, why should you consider nursing? There are 4 main fields within nursing. So we have adult, child, learning disability and mental health. You have that ability to work in a variety of environments, and you're going to hear about some of those in a moment. And you have that ability to change direction. So I started off as a care of the elderly nurse, for the want of a better word. I'm now working in education, but I have worked for the same organisation who have supported me through education, through the opportunities to explore what it is that interests me. And your interests may change as you go through your career. And actually, it's a recognised qualification across the world. And again, you may hear about that, or you will hear about that in a moment. It is a qualification that can take you anywhere. So that is why I would consider nursing. And I'll hand back to Rachel.
Thank you, Diane. That's really interesting. The varied roles you have. So interesting. So thank you very much for your time. So our second speaker is John. John is going to be talking about the differences and similarities between nursing in the UK and the Philippines. So I'll let you take it away, John.
Okay. Hello. Good afternoon, everyone. My name is John. I'm an adult nurse. My current job role is I'm a practice education facilitator, and I'm working in an acute hospital, part of the education team supporting our learners and new registered and qualified nurses. Next slide, please. So, give you a glimpse of my career journey. So, I was a registered nurse back in the Philippines back in 2008. I have done a corporate job to begin my working years for a couple of months, for 7 months. This is because initially I never wanted to become a nurse. This is not something that I have considered doing for the rest of my life. So I ventured into a corporate job, but one day I come home and said, what value do I have by doing this corporate job? The answer was, there was no value at all. I was not able to contribute to my community. That's my feeling. And then I decided to go back to nursing and hoping for, you know, a good comeback. And from that time that I came back to this profession, I have never left since then. And then back in 2009 until 2012, I was working for the government back in the Philippines under the Department of Health. I was looking after a population of about 6 to 7 million. I am doing and focusing on blood safety program. And then after that good 3 years of working for the government, I decided to work outside of that comfort zone that it has created me. And I went to the Kingdom of Saudi Arabia. I started working there in 2013 until 2018. When I arrived in Saudi Arabia, I started working as an emergency department nurse. I have done that for a couple of weeks, about 6 to 7 weeks. But then after that 6 or 7 weeks of working in the emergency room, I was asked to lead the quality and patient safety department for the hospital. So looking at quality improvement projects, risk assessments, patient safety plans, including infection control, and also looking after incident reporting in the organization. And then I've done that job for good 4.5 years. And then I was also part of the nursing education in the hospital I work with in Saudi Arabia, looking after a team of educators as well, making sure that an educational plan is in place, that there is a strategic educational development program, the competency program, the preceptorship program that makes sure that we are supporting all our colleagues in the nursing profession, making sure that once they get employed within the organization, that there is that progression and the ability to develop themselves further in the profession. And I was also part of the nursing administration and leadership of the hospital back then. And after my 5 years of stay in Saudi Arabia, I went back to the Philippines, and then again joined back in the Department of Health. doing the same thing about blood safety. I was a nurse supervisor for the laboratory medicine. So that's where my focus is. And I handle about 18 to 20 nurses under me. And after that, I came in here in the UK as an adult registered nurse. I arrived here in 2020 during the height of the pandemic. Until the present, I am still working in the same organization till now for over 4 years now. And I started as an adult nurse in an isolation ward. So during the height of the pandemic, I was, first line, face to face, and in come in contact with, direct care provision to our patients afflicted or have been infected with COVID and other infectious diseases. And after a couple of months working as an adult nurse, I there was an opportunity to join the education team of the hospital I am currently working, and from that time on until now, I am still working in the same team. Yeah. Next slide, please. So, but I'll be highlighting to you the day in the life of an adult nurse. Okay. There's nothing much difference of being an adult nurse here in the UK and in the Philippines. Um, the routine care or the routine plan of daily activities is the same. So we usually start off with the handover. So if you can see there, there's nurses doing the handover, making sure that complete and correct and accurate information is being handed over from the previous shift to the incoming shift to make sure that there's that continuity of care. And then once the handover is done, we then focus into making sure that the patients are given their medications that is due and that is timely and that is safe for the patients, also considering that patients are consenting to those care requirements during the entire day. And after focusing on giving of medications, we also make sure that we also give care, direct care for our patients. We look after patients, make sure that the patients are clean, that they are, that their hygienic requirements are being addressed, and make sure as well that we move them from bed to chair just to keep them up and running, assist them with their daily needs if there's any assistance that they require, but at the same time promote, making sure that we also promote that independence, making sure that we prepare the patients with them going back home if they recover. But if, in the case of, peaceful of death of our patients, we also make sure that the patients are being given that dignity that they deserve until the last um, few hours of their life. We also collaborate with our other healthcare workers and other healthcare professionals. So we make sure that we contribute during doctors' rounds, and we discuss the care of our patients to our allied health professionals like our physios, our OTs, making sure that we get it right for the patient and what is essential and what matters to the patients are being tackled during these conversations, so that in the plan of care, those aspects are being considered, and we are coming up with a plan of care that is not just collaborative, but there is participation of the patient and the relatives if necessary. Okay. And then with a plan of care, we have to render that, making sure that with the provision of care that we have for our patient, we make sure that it is safe and with the utmost quality that we can provide for our patient. Because at the end of the day, um, our patients come to the hospital with full trust and confidence in the healthcare workers that they have, that we will be the safeguards of their safety while they are so unwell and they are battling some, diseases and illnesses. And then we make sure as well that whatever that we have accomplished for the day, we document it, because what is not documented is considered not done. And it also just makes sure that the continuity of care for the patient is not compromised by making sure that we take an up-to-date record of everything that we have done. But while working as an adult nurse, as what our previous speaker has mentioned, Diane, You don't have to worry when you are new in your role as an adult nurse or new to the working environment, because there will always be support that will be provided. I myself was a recipient of that support when I started here in the UK, knowing that there are some differences of the system. So when I started anew, I was have given that support through the preceptorship program. So the preceptorship program has given so much input and has equipped me on things that I needed to know to be able to equip myself and to also be able to integrate properly into the role. And there will also be mentors and supervisors that will be there, and senior nurses and colleagues that will be there to be able to assist you and help you integrate into your role. It can be anxious coming into work when you are new, but knowing that there's kind of support and there will be colleagues who will be kind enough to understand that you are new for the job is, quite reassuring as well. And also, while doing all these things, you also have to be guided that you need to make sure that in everything you do, you also adhere to standards of professional practice. Okay. Next slide, please. So the challenges that I have encountered, this is probably, not unique for everyone, but this is what I see and what I have encountered as an international nurse as well. So coming here with a new work environment has been challenging, because you will have to deal with a different setup and a different culture, different kinds of people, very diverse as well. It is a challenge to begin with, but now having been able to integrate myself, this is actually a privilege and an opportunity to be working with so much diversity in the workplace. Next, the new culture and systems of working, because though you know care is universal and it doesn't change the rationale why we do things, but sometimes the way of working is quite different, and those are the things that we need to adopt and adjust ourselves into, not necessarily forgetting the things that we learned before, but it's about enriching the things that we have learned to be able to grasp this new culture, these new types of working, and be able to make yourself a better experience and a safe professional to practice in the profession. Next is communication, because understandably, me coming from the Philippines, English is not our first language, though it is taught in the schools and colleges and universities. But it is still different that you come here and you still express yourself in the language that everybody needs to understand, especially that we have different ways of expressing ourselves, and the use of words also matters. And this is a challenge that I think most of international nurses face, but it's a matter of how much we embrace as well and how much we expose ourselves, because at the end of the day, communication should not be a hindrance to how we should be able to deliver care. And next is staffing challenges. I think there is no hospital in the entire world that is not facing any staffing challenges, but it's just a matter of how our team works well together. That's where teamwork can come in to be able to make sure that the impact of staffing challenges is being managed. Um, it's where competencies as well comes in, because if our staff are really competent, we don't need some other extra help to be able to deliver care, because we are already equipped of that necessary skill and competence. Next, there will be difficult patients and relatives. I This is kind of a daily scenario probably in any organization, because there will always be difficult patients, because we have to understand patient comes into hospital not in the best version of themselves, because there is that pain, there's that discomfort, there's that stress, there's that anxiety, and who can function in the best way that they can in those situations? No. So there will be difficult patients and there will be relatives, because there is the anxiety level of what will be the outcome of this admission or this hospitalization. But this is where our bigger understanding should come in. And we should just have to be more patient with our patients and be able to give that kind of understanding and compassion and empathy to the patients that we look after. Next, there will be one of the challenges is maintaining emotional and mental well-being, because as the pressures right now of of our hospitals getting so full with patients being admitted. We are looking after very sick and frail patients as well. It can cause so much emotional and mental stress on us, and it really requires healthcare professionals to be able to look after ourselves as well, emotionally and mentally. And that is why our organizations are having our well-being support team. There's colleagues, well-being champions that are there, that when we feel so stressed and we need somebody to talk to, just to unload, probably there will always be those people. But you can always talk to your senior staff nurses, to a friend at work, or to your ward managers. They will always be ready to do that. And I think everyone in healthcare now is always ready to give that shoulder to depend on during those difficult times for our colleagues, because we understand what it is at the moment. And also cultivating resilience. You just have to make sure that you're strong enough, but you also don't put so much stress on yourself to eventually break down. And resilience is that inner strength, that inner core, and your ability to be able to rise above the situations. Okay. And next slide, please. And the rewards I consider of doing this job as an adult nurse, it's beyond money. Personally, um, it's the experience of service. Nursing for me is not just a profession, but it is a commitment to something bigger than just the profession, because this is really service, that desire to be able to serve those who are not able to look after themselves in their most vulnerable situations. There is that joy of care, that joy that you get when somebody is able to recover, somebody gets better with the help that you have done, with the care that you have rendered, with the planning and with the conversations, with the collaborations that you have done, and you see that person get better every single day. And there's that smile for a smile. um, Most often smile is an expression, it's a gesture, it's an act. But sometimes in healthcare, smile can become a language when our frail and vulnerable patients can anymore speak because of their condition, because of being too weak and too frail. That smile says a lot, and that smiles, says 100 words of appreciation and gratitude. That and that affirmation that we need as well during the day, that somehow if that patient is unable to communicate clearly what they need, that smile tells you that we are getting it right for that patient. And we become safeguards of the vulnerable, and we become their advocate when they are not able to you know say it for themselves because of their condition. We become their advocate. And there's that appreciation of the human journey in the health continuum, because we are there present from the first cry until the last breath. And it is just so much privilege to be able to witness this on a daily basis, because no other profession will be able to give this experience to anyone. It is just in healthcare. Next slide, please. So the advice to my younger self, what I will say to my younger self is, you define your own timeline, because most often now our younger generation are so stressed with with timelines. We always compare that our colleagues, our friends are already this, and they have already reached this kind of goals for themselves. But don't stress yourself. You define your own timeline. You are in no competition with anyone else, but the best competition that you have is yourself. How much about yourself do you want to grow? How much of yourself you want to get out of your comfort zone, and to continually challenge yourself to make those progress necessary for you. But while doing that, always remember to be kind, be purposeful, and be intentional. You always have to come to every situation with a purpose and with great intention, with kindness. Next slide, please. And the impact of time. This is an unforgettable situation that I had experienced, and this has really stick within me and in my memory until now. I put there these patients. They are people. Our patients. They are people. They see people. Okay, they are surrounded by people, but sometimes has not been afforded time by people. Um, with this job role, I am quite privileged to be able to move around the hospital and see patients because I support colleagues and our newly qualified and new registrants. I came to a patient in a bay, and she was quite grumpy. She was quite lonely. She was not quite engaging. And when you ask her a question, she's quite in a different mood. She hardly smiles and she hardly give you that pleasant look. But when I went there and I started having conversation, I showed that I was interested in her. I asked how she was, how was the night was she comfortable at night, what she had the morning, what did she enjoy during her breakfast? Did she had enough food to eat during breakfast? Was she comfortable? Is there anything that I can make her be more comfortable? She just suddenly broke down and she cried. And she said, I've been here in this bed for 3 or 4 days now, but no one has really stopped to be able to spend some time with me. She's not she's not taking it against the healthcare professionals because she understands that it was too busy, but there was so much appreciation when she realized that someone in the profession, someone wearing that uniform in the organization is able and is willing to spend 5, 10, or 15 minutes of the time. He said, I'm not going to waste your 15 minutes. I said, 15 minutes is no waste if you feel that your dignity has been recognized in this whole encounter. Yeah. And yeah, so I have not been out of this profession for more than 15 years now. I am still enjoying coming to work every single day. And I hope you will consider coming into adult nursing or just nursing in general, because there is so much joy in this profession. Thank you very much.
Thank you, John. Some lovely words there. Very nice. Thank you for sharing your sort of wisdom and what you've been doing. That's lovely. Thank you. So now I'm going to move on to our third speaker, and that is Gill. Gill is going to be talking about occupational health nursing.
Hello, my name is Gill, and I am currently working within the education team as a practice education facilitator, and I work in a local hospital. Next slide, please. So my career journey is probably a little bit different, the journey that I've taken throughout my career. I qualified as a registered nurse in 2003. Prior to that, I'd worked in industry as an engineer, working in a fuel injector company. So I started my nursing, say, 2000 and qualified in 2003, where I worked as a general emergency surgical nurse. And I worked in the trust delivering the care that John has talked about for 3 years. But then an opportunity came up. My children at that time were 4 and 9, and I had the opportunity, or myself and my husband, we considered maybe emigrating abroad to Australia. So I applied for a few jobs in Australia and was lucky enough to have secured a post in a trust in Western Australia in Perth. So we upsticked and we moved all the way to Australia, where I worked as a general surgical nurse in an Australian hospital. But sadly, my husband didn't settle. So after a year, we kind of like had put the things in place to come back to England. When I worked in engineering, I was very, very friendly with an occupational health nurse advisor, because in industry you quite often have occupational health there to help support as nurses, workers in the workplace. She had known that I was coming back to Australia, coming back to England, sorry, and she contacted me via email and said, I heard you're coming back. Would you be interested in working in occupational health? Because of my engineering background and giving me that understanding with working in industry, and because of my nursing background, they really married up really, really well. Again, I had a conversation with her and the occupational health physician whilst I was still in Australia, and they offered me a post on my return. So in 2007, I came back to England with my family, and I started working for a private occupational health company. Obviously, this is something that I hadn't done before. I'd done nursing before, but hadn't worked as a nurse in industry. Within the company, they provided occupational health for numerous industries, for utility companies, for local councils, and local authorities. So part of the role that I had within that was going into, as I said, different industries, at first with somebody and then going out on my own, doing various tasks, which I'll talk to you about in a slide this time. And I worked in that job for 4 years. And then after 4 years, I really missed the clinical side of patient care, because everybody that I was seeing was relatively well, and I didn't feel that I was actually fulfilling my caring need, the reason why I came into nursing. So I was lucky enough to secure a post as a sister, working back on the general surgical ward where I first qualified. And whilst I was working on that ward, I took an interest in looking after students, and I then asked, I then inquired about roles within the hospital around education. And after a couple of years of working on the ward, I went and worked for the same team that I'm working with now. And then after doing that for a couple of years, I'd taken on my master's and achieved my teaching qualification, and then decided to go and apply for a local university. Again, I was successful to be given the post of an adult nurse lecturer. And sort of following on from that, I had then there was a lot of travel involved in that, and I decided then that I would apply back to occupational health. So I came back into occupational health, and then after doing that for another couple of years, I again missed what I was doing before and went into education, but within the hospital, and became part of the education team again. So you can see that going from an engineer to qualifying as a nurse, how that journey can take you not only into different aspects of nursing, but also the world is your oyster. And once you've got that English UK RN status with the Nurse and Midwifery Council, it's recognised in across the world, and Australia, Canada, America, they all are looking now for English registered nurses. Next slide, please. So the day in the life of an occupational health advisor. So when I first started off, I was just an occupational health nurse. And after several months of going out with other people, I was sponsored to do my occupational health diploma, which I did at Warwick University. And whilst doing that occupational health diploma, I then took on a lot more responsibility working with occupational health. So the day of the life of an occupational health advisor could be that I went into a company and did health surveillance, and that health surveillance could be respiratory health surveillance, it could be noise health surveillance, it could be fork truck driver health surveillance. So it was very, very varied. So I would be testing people's lungs to see if the materials that they were working with, the dust, etc., was being sensitizing them, individuals, and giving them respiratory problems like asthma. I could also, because industry can be very noisy, doing hearing tests to make sure their hearing hadn't deteriorated. I could also be doing within that, the fork truck drivers, which also included things like diabetes checks. And then once I'd done all that health surveillance, I would then do a report to management. And anybody that raised any concerns with their health from the health surveillance, I would then refer on to our occupational health physician and support him in doing further examinations with the individuals. I could also be doing management referrals as well, so sickness absence management. So I was expected to see 6 or 7 people in a day, and they would be referred by their manager because they had either a workplace issue or had a long-term health issue. And occupational health, really, in 3 words, is fitness for work, and it was about trying to get the person back into work. With reasonable adjustments, etc., because work is good for you, and people that are off sick quite often can spiral into mental health issues because of not being at work. Work gives you that kind of stability to daily life. So that was quite a big part of my role as I got further and further down my diploma, and then successfully passed my diploma. That involved me using communication skills, having the courage to talk to line managers, liaising with HR, human resources, and making suggestions about how we were going to make reasonable adjustments to get people back to work. So I always, at first, I was quite nervous making these decisions for people, but I found that using good communication skills and working one-to-one with managers and HR and the individual as well, we quite often successfully got people back into work quite quickly, or we helped with the maybe taking early retirement route if that work was making them at a point where they actually couldn't go back to work because they were ill. I'd also do some clinical exams as well. So people that used hand-arm vibration equipment like drills, road work machinery like kangos, that kind of thing. Any machine that vibrated could give people a lot of problems with their extremities, so their fingers, musculoskeletal, their shoulders, their arms, etc. So I would do physical exams with people using pin boards, looking at dexterity and things like that. And again, doing that mostly with a physician of occupational health, so to make that clinical judgment between as a duo, if you like. So I did that quite a bit. Also, part of Fitness to Work was trying to keep the workforce healthy as well. So we did a lot of health and wellbeing events where we would do little sessions where we would do blood pressures, we'd do urine dipsticks, we would be doing things like checking cholesterol to make sure that the workforce was healthy, but also then giving further advice and giving lots of opportunities to them to come and talk to them about, talk to them about healthy eating, fit health and fitness exercises and things like that to try and keep the workforce healthy as well. So say I did that for 4 years, and I did enjoy what I did, but a lot of that was going out. They call it peripatetic, where you would be based in a town and then you would have to drive to different industries, which could be 100 miles away. And sometimes we had overnight stays as well, where we were doing 2 or 3 days of health surveillance at a time. So that was one part of the role that I've done, and my other role that I've had as a nurse is a nurse lecturer at the university, where I took on the role of looking after nursing assistants that were wanting to progress within their career and take on the foundation degree. And as a foundation degree progresses, you can actually go down that route to become a nurse. So that's what I was teaching at the university. But part of that role was not only teaching, it was also as a personal tutor, where you would be providing not only help of a academic nature, but also pastoral support, where a student might come to you that actually thought that they weren't able to complete the course, they weren't able to meet deadlines, and then you would help them and give them some strategies to help them get their work in on time, or help them with asking for extensions, etc. So I was a teacher, lecturer, so I did a lot of lecturing, teaching the future nurse, and that was a really enjoyable role. Got to meet lots of people. I had imposter syndrome for quite a while because here I was, ex-engineer, now working as a nurse, and all of a sudden I'm somebody that nurses are looking up to. So really struggled at times with that role until I got more mature in that position. Some of that role also included marking. So everybody that submitted work would it all need marking. So a lot of time was spent marking work as well. And also being a link lecturer. So part of my link lecturer role was going to the local trust where I'm at now, and linking up with the education team, but with a different hat on. So I worked with the education team for the university, not actually working in the hospital. So that was really good as well. So I was that person that helped to link our students at the university with their local trust. And that was a lovely role as well, because I still felt I was keeping my links with within education, within the trust. Next slide, please. So I've kind of done rewards and challenges as a joint slide. So some of the challenges that I found I found so far as being a nurse is with the lecturing role, and also with the occupational health role, because lecturing the foundation degree, it was decided that we were going to teach on various sites for the foundation degree. I could be travelling in my car anywhere from Great Yarmouth, Lowestoft area, right the way across to Cambridge or Kings Lynn, and then into Ipswich, and then to Bury St Edmunds. So I could be travelling a whole week, but also teaching as well. So that was a huge challenge, because it was very, very tiring. And I really did find that trying to look at curriculum and look at things that I was delivering was quite time consuming, as well as the driving. And also, because of the peripatetic nature of occupational health and going into different industries and overnight stay when I had children at home, it was quite challenging as well, because again, a lot of driving, and of course staying out overnight wasn't ideal. Some of the another challenge that I had, I was an RCN, Royal College of Nursing steward, and I belonged to our local branch, and I foolishly volunteered to deliver I can't think of the word, to deliver a speech at Congress, and that was in front of 4,000 people. And I'd beautifully straightened my hair before I went, and then I was so nervous, it absolutely chucked it down with rain. I got absolutely soaked. So there I was on stage in front of 4,000 people, talking about the use of covert surveillance in nursing homes, which was a really tricky subject to talk about, and very emotive. It was the most scariest thing I have done in my life. So that was very, very challenging. But then equally, some of the rewards that I've had, I have found that my communication skills have improved through all the work that I do, talking to patients, talking to relatives, talking to managers, talking to HR. You learn to use languages of a higher nature. I've continued with my master's. Again, you're reading language of a higher level. So communication skills, I feel, have improved. The brain cells are starting to go slightly with age, but my communication skills, I believe, are improving every day. Being in big classrooms, I absolutely love having classrooms, having people to talk to, students to talk to, being up there, hoping and trying to be a role model. I may not make a difference on the wards now, but I'm hoping that within the classroom, because of the way that we teach what we teach about clinical skills, about professionalism, etc., that we are making a difference in the classroom, which then will transfer to the ward areas as well. Another reward that we had a couple of years ago was our pastoral care award. And I think that the pastoral care support that I provided within as a lecturer, but also in occupational health as well, helped to give qualities to gaining that award as well. Next slide, please. So my advice to my younger self would be, it's okay to fail and keep trying. Unless you're willing to fail, you're never, ever going to succeed. I failed along the way. Everybody has to fail, but you learn from your mistakes. Every day is a school day. I learn, or I try to learn something at least every day. I say to my children every day, what have you learned today? What could you do tomorrow that's different? So that would be my just don't worry about failure. Just keep trying. You'll get there in the end. Next slide, please. So making a difference as an occupational health nurse, I felt that I helped employees back to work with robust advice, with health surveillance, keeping employers, helping employers ensure a healthy workforce. Lifestyle clinics were about monitoring and giving that healthy advice to staff. And then I did a lot of vaccinations with flu, with COVID, but also travel immunisations as well, because some industries, some of the employees did go abroad. So it was about giving advice and travel immunisations as well. Next slide, please. And then making a difference as an educator, I hope that I am educating the future nurse academically. That is what I try to do every day. Teaching clinical skills, part of the OSCE team, which taught international students on clinical skills, but also within lecturing, taught basic clinical skills as well, basic life support, injection techniques, those kind of things. I gave hopefully good support through academic pastoral support and care, and then helping others to succeed in a rewarding career. Next slide, please. Would I do it again as a younger self? Most definitely. Hindsight is a wonderful thing. In my younger self, when I started in engineering at 18, if I had I didn't have the qualifications, to be fair, then, but I would have, if I knew what I knew now, I would definitely have gone back to school, got the qualifications that I need, and started nursing sooner, because it has been the most rewarding job that I've ever had. Becoming a nurse has opened so many doors for me, not only in this country, but also on the other side of the world too. And making every encounter count is so rewarding. I love my job. Every day is so different, and it is so rewarding every day. Thank you.
Thank you very much, Gill. It's lovely, and I think you'll see the theme over everybody about all the different job roles that you've had. So it's really lovely to hear. Thank you. And so we move on to our final speaker, Vicki, who will be talking about her role in community nursing. Thank you, Vicki.
So good afternoon. My name's Vicki. I'm a registered nurse, adult branch, and at the moment I'm working in an NHS trust which provides acute and community services. Next slide, please. So I left school at 16 and went to college, went to the local college, and I did a health and social care level 3 course, so the equivalent of what would now be a BTEC. I had a year out after that, and then I applied for and was successful in getting a place on the adult nurse training at my local university. So again, staying sort of close to home. I did a 3-year adult nurse course and completed that successfully. When I had finished, I then went and worked for a year on an acute medical ward, again, sort of staying local, staying within the county. So the medical ward looked after people with medical problems as a opposed to surgical ones. So we would get patients with things like chest infections, things like skin infections, people that had strokes, and yes, I did that for a year, and then I decided that I wanted to try something different. As you've kind of already heard, there's lots of different things within nursing, and I was never really sure where I wanted to go. So I decided to apply for a post as a community nurse. And I was successful, and I stayed in the position of community nurse for 15 years. So I did move a little bit around the county in that time. I worked in 3 different teams, but it was still in that community nurse role. And then 8 years ago, decided it was time for another change, and I started working in healthcare education. Initially, that was just in the community, and then community and acute. And again, now my focus is on community. So during this presentation, I'm going to focus on my career as a community nurse. Next slide, please. So typically, a day in the life of a community nurse, and just kind of to bear in mind, lots of people, when they think about nursing, they think about hospitals, they think about sort of sick people, but actually most nursing interventions happen in the community. They don't happen in hospital, and a lot of nursing intervention isn't about sick people, it's about well people. So there are 6 bases across the west of Suffolk that deliver adult community nursing, and so typical day in the life, we'll go into that base in the morning and receive a list of patients that you need to visit that day. And you will then gather up the kind of the things that you need to deliver that care, go off on your car and see those patients, and the kind of interventions that we would be delivering as community nurses. We would be administering medication, but the medication that we administer wouldn't be oral medication, so not tablets. They would be medications that needed to be delivered by specialist routes, so things like injections. And so, you know, for instance, insulin was one of the medications that we gave quite a lot. Insulin injections for people that were no longer able to give their own. So that formed, you know, a quite a decent amount of our workload. Catheterization is another thing that community nurses do quite a lot. So when people have a catheter in, it needs to be changed every 12 weeks, or if it gets blocked. So we would often have those patients on our list. The intervention that we delivered most often, I would say, was wound care. So we would do or see lots of patients with leg ulcers, pressure areas that had broken down, so they'd got pressure sores, patients that had got surgical wounds, or patients that had got trauma wounds. So by trauma wounds, we mean wounds that had happened because they'd had an accident. So for instance, walked into a car door was quite a common one for elderly people with fragile skin. So we'd see those patients and we would dress their wounds. We would see patients who were coming to the end of their life, and we would provide symptom management for those patients. So in the very kind of last sort of weeks, days of life, we would administer medication to those patients via a continuous infusion. So we would be looking at making sure that their pain was managed, looking at making sure that they weren't agitated, so they were settled, making sure that they weren't feeling sick or nauseous, making sure that their families were well supported, sort of emotionally. So we would see those patients. We would see patients that needed equipment to be ordered for them. So we would go in and assess for pieces of kind of clinical equipment. So things like commodes, hospital beds, pressure relieving cushions, catheter stands, those sorts of things, and we would be able to order those for the patients. And if they had a health need for them, they were eligible to have those items for free, delivered from an NHS budget. So we would see those patients in the morning predominantly. Some of them would also be in the afternoon, but once we'd seen and done a kind of a morning round, we would then go back to the office, and some of our colleagues would come back to the office as well. We would have a handover, so talk about the patients that we'd seen, what care we delivered, and what care they needed in the future. It was also then a time where we did quite a lot on the computer. So we would write up our visits on the computer. We would also do any kind of referrals that we needed to do, order equipment digitally. And also within Suffolk, community nursing visits are managed predominantly digitally. So there is a care coordination centre in Ipswich, and they take most of the referrals for community services. They will then electronically send those to the district nursing teams, who will then kind of filter them out and work out how they're going to fit in seeing those patients. In the afternoons, we would then pick up any extra visits that we got, so what we would call SOS visits. So if patients had, for example, sustained a wound that day, or if their catheter had got blocked, or if someone had been discharged from hospital and needed some medication via an injection, but that hadn't been, we hadn't previously known about it. So we would go out and see those patients then in the afternoon, and then meet back in the office usually before we went home at the end of the day. So that's kind of a typical day in the life of a community nurse. Next slide, please. So the challenges of community nursing. So obviously, when you're delivering community nursing care, you're in patients' homes. And when patients are in their own homes, assuming that they've got capacity, they can choose to live any way they choose, and they can choose to have any pets that they choose to have. So, obviously angry dogs are a bit of a problem. We would ask for those to be put away. But friendly dogs are also often a bit of a problem, because they like to get involved. They like to walk over sterile fields. They like to, walk between you and the patient and generally just get in the way. I have seen goats in kitchens, which can be a bit of a challenge when you're trying to wash your hands. And I have also seen or been into a house where they had a parrot who expressed his dislike of our visits in the most colourful of fashion. We've also, I've also seen like a duck being nursed in the kitchen on NHS incontinence pads, and I've been chased across fields by geese, and and those sorts of things. So yeah, and animals do tend to be a little bit of a challenge that they don't have to encounter within when care's being delivered in hospital. Next slide, please. As I said, patients can live in the way that they choose. So if they choose not to do their washing up, it's completely up to them. But obviously, we know how important hand washing is. So when we've got a sink full of washing up, it's more challenging than it might be in hospital sometimes. We do have some little kind of workarounds, but and we still do perform hand hygiene, but it's not as easy as it would be in hospital when we've got sinks that are full of dirty dishes. Also, a lot of our patches are quite rural. It can be several hours between us being at the office, and so there's a lack of toilet facilities, and our patients' toilets are not always where we would choose to go. So yeah, you get good at holding your bladder, and also good at knowing which houses are okay to ask if you can use the facilities, and which ones you're better off passing and wait until you get somewhere more suitable. We're also going to houses where people are hoarders. So I've certainly been into houses where I've had a tiny little pathway to walk along, and a tiny little pathway in a tiny little gap in which to bend down to get to somebody's legs to dress them because of the hoarding. So again, it's challenging. If patients need to lie down and have an intervention, if they're a hoarder, often there isn't anywhere for them to lay because the bed is full of whatever it is, newspapers, rubbish, just piled up with papers. The sofa is piled up with papers. So you get very good at adapting the care that you deliver so that it's still safe and still effective, but you are doing it within the constraints of the environment that you're delivering it in. Next slide, please. Some more challenges. So community nursing happens 365 days a year, and that does include the days when it snows. So there are some patients who absolutely have to be seen every day. So patients, for example, that need insulin, they absolutely need their insulin every day, and that includes when it's snowing. So that can definitely be a challenge. I've worked in a team where the team leaders borrowed a tractor off of a farmer that lives next door so that we can get to those patients. So we do get there, but it's obviously more challenging. You are a lone worker for a lot of the time in the community, so there is a team, but when you're delivering that care, you're delivering it on your own. And you don't go around in pairs like on Where the Heart Is. So you have to be quite confident in what you're doing, and you have to be quite happy to be alone and going into strange houses with people that you don't know, completely kind of on your own. And then also one of the challenges, depending on where you're working, can be kind of just the simple logistics like parking. If you're working in a town environment, that can be a struggle, and need to learn to parallel park. Next slide, please. But the flip side of those challenges is that there are lots of rewards. So when you are delivering care in the community, when you're delivering care in patients' houses, you get to truly build up relationships with patients. You're on their territory, you're there on their terms. And some of these patients we do care for like decades at a time. Some not, some it's short and a couple of weeks, but some patients it's for a long time. And you truly get to deliver person-centered care. Within the hospital, You know, they have to work within the constraints of the way that the hospital is structured. So, you know, meal times have to be when meal times are. You know, doctors' rounds are when doctors' rounds are. The way that the ward is laid out is the way that it's laid out. But in the community, we haven't got those constraints, so we can very much work with our patients. We build up relationships not just with patients and their families, but also with the communities around them. I've also worked in some amazing teams. So I talked about lone working. And as I said, you are very much a lone worker when you're delivering that care, but you do also exist within a much wider team, both nursing wise and multidisciplinary team wise. So, you know, I've worked with some incredible people, incredible, inspiring people who are completely passionate about community care and amazing at what they do. Some of the other rewards of community nursing. Community nurses don't work nights, so you always get to sleep in your bed at night, which for me is a #1 bonus of community work versus hospital. In terms of pay, so a band 5 nurse, which is the kind of level on which you qualify, will earn between 30,000 and 38,000 plus some unsociable hours, which, you know, I don't think's too bad. And then within sort of 3 years, you can then be looking at going up to senior nurse, which is sort of 38 to 45,000 pounds a year. You get quite generous sick pay, you get generous pension. So those things, I think, make the NHS in general quite an attractive place to work. Being in the community, we talked about the snow, but the other side to that is when the sun's shining, you're out there and you get to, you know, feel the sun on your skin as you're walking between your car and the patients' houses, which is lovely. Also, the NHS generally, so not just community, is very good at supporting people's development. So I've done lots of courses that have been funded and that I've been given time to attend while I've been in the community that have kind of aided my development. Next slide, please. So my advice to my younger self would be, what is for you won't go by you. So a wise old nursing sister said that to me once, and what she meant was, if it doesn't work out for you this time, there's a reason for it and something better is coming along. So if you go for a job and you're not successful, don't worry, because there's something better. And when it's meant to be, it will work out for you. And when I look back at my career, when I look back at the things that I've perhaps gone for interviews for and not got, when I look at what's then come up for me after that, without exception, what's come up for me after that has always been a better option than what I was not successful at. So yeah, definitely don't worry if things don't work out. They'll work out for the better in the long run. Next slide, please. And just why do you make a difference in community nursing? So for some patients, community nurses are the only people, or one of the only people, that they have any contact with. For some people, they're an essential part of enabling them to stay at home. Without that community nurse's intervention, they would have to go into long-term care. For some patients, community nurses are what allow them to die, the people that allow them to die at home. They're delivering that intervention that nobody else could, that symptom management, that means that they can die in the place of their choosing. For some patients, the interventions that community nurses deliver are life-saving or life-changing. And you get to build these relationships with patients, with their families and with the community. And when you're caring for people in the community and you're caring for people in their own homes, when it's on their terms, they're generally at their happiest. And yeah, I enjoy looking after happier patients, really. So I would definitely recommend working in the community. Thanks, Rachel.
Thank you, Vicky. Really go, and I did like some of your challenges. You've been very brave in the past. Thank you. Thanks everyone, and thank you for joining us. I hope you found the information today informative. There's been a huge amount of information, so I'd just like to say thank you very much to our ambassadors. We're always interested in your feedback, so please, if you'd like to tell us what you think, please scan the QR code and let us know your thoughts. Thank you very much.